To our listeners, if you're a man and you're at the age of 40 or above and you have not had a PSA test yet, please have a PSA test next week and show the result to your family physician or to your urologist. Move. What move I mean is to exercise. You can walk, you can run, you can ride a bike, you can swim, you can play tennis, golf, whatever it is that you like, but you should be moving because we know that exercising decreases the risk of prostate cancer. Eat healthy. As I said, a Mediterranean type of diet with vegetable-based, whole foods, unrefined is ideal. Less fat. Fat should be from olive oil. Less sugar is suggested. Don't smoke. For the last couple of years, we have learned that smoking is a risk factor for development of prostate cancer. Don't get fat. A belly really doesn't go well with your prostate health.
30 years ago in 1991, a small hospital welcomed its first patient in a district of Istanbul, Turkey. Acibadem was the name of that district. Today, Acibadem Healthcare Group is a global brand providing superior medical services in Istanbul, Ankara, Bursa, Eskişehir, Muğla, Kayseri, Adana, and Izmir. Through acquisitions, our footprint expanded to Macedonia, Bulgaria, the Netherlands, and Serbia. In 2012, Acibadem signed a joint partnership with IHH Healthcare, becoming a part of the world's second largest healthcare group. Today,
Bine v-am regăsit la un nou episod de podcast BZI, sunt Viorela Dimici. Astăzi avem un invitat care a făcut drum lung pentru a ajunge în studioul nostru. A venit tocmai din Turcia pentru a ne oferi răspunsuri despre cancerul care este întâlnit foarte des la bărbați. Unul din bărbați are cancer la prostată, respectiv astăzi discutăm despre acest subiect și despre cele mai noi tehnologii în acest domeniu. Alături de noi este profesorul și doctorul Öbek, respectiv ne răspunde la toate întrebările cele mai frecvent întâlnite de la pacienți și facem claritate. Până începem interviul, vă spunem că partenerul nostru principal este Balkan.ro. În momentul în care faceți cumpărături pe site, aveți în continuare reducere 10% la orice produs pe care îl cumpărați. Ceea ce trebuie să faceți pentru a beneficia de această reducere este să folosiți codul BZI10 la finalul comenzii. Ținuta pe care o port astăzi este semnată de brandul Conceptatua. Pe această cale le mulțumim pentru că au mereu grijă de imaginea mea. Iar eu zic să începem și să facem un pic de claritate. Hello, Dr. Can.
Hello.
Welcome here in Romania. Welcome in our studio.
Thank you very much for the kind invitation. Thank you.
It's a honor for us to have you today here at Podcast BZI because, as I said earlier when I start my speech in Romania, I said that 1 from 8 men have prostate cancer. So I think it's very important to talk more about it and to give good information for Romanian people who will look at this interview. So first question that I give to all my guests is who are they, like to describe themselves? Who is Can Öbek?
So professionally speaking, of course, I'm a urologist and my area of expertise within urology has always been urologic cancers. I'm an Istanbulian. I was born and raised in Istanbul. I did my medical treatment at the University of Istanbul, and then I did my residency training in urology at the University of Istanbul. After that, I realized that although urology is a small specialty, there are different specialties within urology, and I wanted to become a urologic oncologist. So I went to the States for 2 years and did the urologic oncology fellowship at the University of Miami. And then I came back and I worked for the University of Istanbul for many years. In the interim, I went to the States for 1 more year again because laparoscopy and robotic surgery was becoming a big part of urology. So I did 1 year training at University of Washington in Seattle. And until 8 years ago, I was with the University of Istanbul. And then I retired and joined Acibadem Healthcare Group. And I've been working with them for the last 8 years. Maybe I can give you a little bit of insight.
Yes, of course.
I've been in urology for 35 years and urologic oncology for 30 years. I can say that I'm a urologic oncologist who believes that a man is more than a prostate and a penis. I think a prostate cancer patient needs a more holistic approach to support him. He needs us to understand his psychological problems, his anxiety. Am I going to live? Am I going to be cured? He wants to know what he should eat, if he should live, if he should change his lifestyle, how to avoid stress. I think it is it's an important role for us to help guide our urologic cancer patients in that way.
So, like a science person, you said now that lifestyle also influenced the developing of this disease. How lifestyle impact cancer prostate?
Lifestyle definitely impacts prostate cancer. The more industrialized a country is, the more you begin to see prostate cancer, that's for sure. If you exercise, if you have a healthy diet, if you avoid stress, then your chance of getting prostate cancer is less. And if you are a prostate cancer patient, and if you can do these changes in your lifestyle, then your response to any treatment will be much better. There's a lot of scientific data showing us this. And what is a healthy eating? Basically, it's a Mediterranean style of eating. Lots of vegetable-based whole foods, unrefined, less sugar, not getting obese, and not eating a lot of fats. The fat should be olive oil. This is a very basic thing, and then there are very details. But in general, if a man eats a Mediterranean style food, his chance of getting prostate cancer is less. This is evidence-based medicine.
It's very interesting to know what determined you to become an urology doctor.
Well, I have always wanted to become a physician. In my yearbook from the primary school, that's when I was 11 years old,
wow.
It says that we wish the best of luck to our friend who wants to become a doctor. So ever since I've known myself, I wanted to become a doctor. I think in the family, my uncle has had an impact on this because he was a physician. He was a professor of internal medicine and nephrology. I liked him, respected him a lot. And I think he was a role model for me. But I always wanted to be a pediatrician. And when you're in medical school, you visit different departments. You spend some time in each department so you can get a better feeling of what those physicians do in daily life. And in my 4th year, I did my pediatric department study. And then I said, maybe that's not for me. After all those years wishing to become a pediatrician, I said, maybe not. And then in my 5th year, towards the end of 5th year, I did urology. And I said, well, I guess I like this. You know, it's hard to put in words, but it's a feeling you get towards that specialty. You say to yourself, well, I think I can do this for the rest of my life. It's kind of life like marriage, no?
Yes.
You devote yourself for a lifetime mutual working.
What do you feel when you see the persons that you treated from this disease, like prostate cancer, and you see them alive, you see them happy, you see them, they have family, wife, children, and you know that somehow you impact their existence and life and you treated them. What do you feel when you understand that you save lives?
Well, that's the satisfaction of this of being a physician. That's why you want to become a physician, I think, because it's this fulfilling, satisfying feeling that you could help somebody, right? That's the role of in life for a physician: help your patients get better and, if possible, get cured. And of course, I feel very happy for them and their families. There's an anecdote I want to tell you before I forget. It's interesting, and I've never told this in any other podcast or show, really. But here's the thing. This is one of the things that makes me happy, that I could help millions of men. And this is it. Prostate biopsy is done under ultrasound guidance. We do a transrectal ultrasound, and with the ultrasound, I think we will talk about biopsy more, but this is something else.
Of course.
Under ultrasound guidance, we take samples from the prostate. So at least 12, sometimes 15. In recent years, we did 20, 30 pieces of needle going in and out of the prostate. And until 2000, this was done without any local anesthesia. Urologists thought that this was a painless procedure, although the man was in a lot of pain. And, we make a joke. It depends on which side of the needle you're at, right? If you're at the needle not going into the patient, it's painless. But when you're the patient, it was a painful procedure. In 1997, someone called Nash from the United States published a paper in the Journal of Urology. He said, we can do a local anesthesia before a prostate biopsy that decreases the amount of pain the patient feels. Unfortunately, nobody picked it up. But in our department at the University of Istanbul, we picked it up and we started doing this procedure. This is 1998, 1999. And then I went to University of Miami for my subspecialty training, and I worked with Dr. Mark Soloway, who's one of the opinion leaders in urologic oncology. He's still actively working. And when you're a fellow, during your 1 year, you have to give 2 lectures. And my first lecture happened to be on prostate biopsy. And I said, now there's a local anesthesia that you can use, and I have experience with it. And Dr. Soloway was very surprised. He said, John, I've never heard of this. Let's try this and see how it works. And we did 50 patients. He saw that it worked fine. We published a paper in 2000 at the Journal of Urology. And then all of the urology community picked this up. And all of the thousands and millions of biopsies performed after that day have been with local anesthesia. So at the end of the day, I can say that I'm very happy. This is maybe my best accomplishment in my career, that I have helped millions of men to undergo biopsy without pain.
Wow, it's really amazing what you are talking now.
It's an interesting story
about. And also during your career, you had plenty complex cases. But which of them marked you the most? Which you remembered the most?
So urologic oncology, urologic cancers deal with cancers of the prostate, kidney, bladder, and testis. I find treatment of testicular cancer the most challenging. More than 95% of testicular cancer patients will be cured. That's a great number. That's very nice. But it's a disease of young men. Testicular cancer is the cancer of men between the ages of 15 to 35, mostly in their 20s. So they're students, or they're just beginning a new job, or they're just planning to start a family. That's the age group we're talking about. And since the cure rate is more than 95%, 99%, hopefully all of them will live many, many years longer. Chemotherapy and radiation, which can both be used in these patients, have side effects that will be seen in 30, 40 years. And the most common of these side effects is secondary cancers. Cancer of the stomach, cancer of the pancreas, cancer of the bladder, because they receive this chemotherapy or radiation. So giving them the optimal treatment is very important. If you give less than the optimal treatment, they may miss their chance of cure. But if you give them over treatment, if you give them more treatment than they deserve, then they will have a lot of unnecessary side effects in their future life. And sometimes surgery in these patients can be very challenging. So all in all, I think testicular cancer patient management requires a lot of expertise, a great teamwork, and a lot of knowledge. Well, of course, some patients make a more impact on your memory than others. Some of these cases are very unique cases. You see once or twice in your lifetime. You don't forget them. Some surgeries are very challenging, very difficult, and you won't forget them. Sometimes you become friends with the patient and the family. Mm-hmm. And that's a good part of our good part of being a doctor, I think, because you make a lot of friends from different parts of the world, from different people, and when you make friends with the patient and their family, you don't forget about them. Surgery comes with complications, unfortunately. A surgeon who has zero complications is a surgeon who never does any surgery. Of course, each surgeon does the best to avoid these complications, but at a certain percentage, surgery has complications. When it's a bad complication, unfortunately, it sticks with you for many years, and you remember those complications a lot. Always we try to learn from the complications. We try to improve our experience with the complications, but they happen and become unforgettable.
Prostate cancer is the most common cancer in men. As I said in the start of this interview, 1 in 8 men will have prostate cancer. Also, King Charles diagnosed with this kind of cancer. So I wanted to know why it's happening so often to men, or there is no answer for this.
We don't know what cancer King Charles has. It's never been announced. So that was diagnosed during or after a prostate surgery, but I don't know. We don't know because it was never mentioned which type of cancer he has. As you mentioned, prostate cancer is a very common problem worldwide. And in Western world, 1 of 6 to 8 men will really be diagnosed with prostate cancer in their lifetime. And based on an article published in 2022, looking at frequency of prostate cancer, out of 89 countries, they looked for 89 countries. Within Europe, the country with the most common increase in the frequency of detection prostate cancer is, what do you think? Is Moldova.
Oh, really?
Yeah.
I'm from Moldova.
Yeah. And this region is
I really didn't know about
really,
this.
Really very close to Moldova. So I think it says something about at least this town as well. And again, out of all the countries in Europe, the country with the highest increase rate in death from prostate cancer is again Moldova. Very interesting. Out of 37 countries, Moldova ranks first, Romania 7th and 8th. So prostate cancer is increasing in this region and parallel with death rate as well. Don't ask me why. I could never know. Maybe the health authorities of Moldova could comment on that. But maybe getting more industrialized could be a factor on this. Because the more industrialized a country is, we know that the rate of prostate cancer increases. So it's an interesting fact. Yeah.
Are there any methods to detect prostate cancer in very early stages?
Yes, we are lucky that we have tools to detect prostate cancer very early at a very curable rate. However, not every man knows about this. So it's our job to shout it loud so every man knows that it is possible. Well, there's a blood test called PSA test, prostate specific antigen, PSA test. And every man should have a PSA starting at the age of 40, 45, the latest 50. In my practice, I suggest everyone to have an initial PSA at the age of 40. PSA increases in prostate cancer. So if there's a high PSA, then we start evaluating the patient, the individual, not the patient yet. You will ask me what's the normal of PSA. Unfortunately, we don't have a number, a magical number that we can guarantee a man that he doesn't have prostate cancer. But ideally, PSA at the age of 40 should be less than 1. And at the age of 60, it should be less than 2. The other tool we have is the prostate physical examination. We do a digital rectal examination and we feel the prostate, the consistency of the prostate. The normal prostate has a consistency of something like this. But if we feel a hardness, like a bone within the prostate when we do our examination, that's a high suspicion for prostate cancer. So we start evaluating that patient.
When men should do it, one time per year or how?
It really depends.
How you recommend to do this?
This is the frequency of at least PSA examinations should be based on the PSA test. For example, if the patient has a PSA less than 1 at the age of 40, the European urology guidelines suggest that you can extend the time to the next PSA for maybe 8 years. 8 years, I think, is very long, is a very long period. A lot of things can happen within 8 years in a man's body. I don't use that in my practice, but if it's a good PSA at that age, I say maybe you can have another PSA at 2 to 3 years. Let's say if the PSA is normal, 2 to 3 years may be a good timing.
Okay, just I understand. 2, 3, one time in 3 years, it's okay.
Yeah,
2, 3
it's
years,
okay.
It's okay. What kind of advices you have to men that are listening us now? What they should know about prostate cancer? What they should do to maybe to prevent this kind of disease, accepting this analysis that you said now?
So to our listeners, if you're a man and you're at the age of 40 or above, and you have not had a PSA test yet, please have a PSA test next week and show the result to your family physician or to your urologist. Move. What move I mean is to exercise. You can walk, you can run, you can ride a bike, you can swim, you can play tennis, golf, whatever it is that you like, but you should be moving because we know that exercising decreases the risk of prostate cancer. Eat healthy, as I said, a Mediterranean type of diet with vegetable-based, whole foods, unrefined, is ideal. Less fat. Fat should be from olive oil. Less sugar is suggested. Don't smoke. For the last couple of years, we have learned that smoking is a risk factor for development of prostate cancer. Don't get fat. A belly really doesn't go well with your prostate health. And we are born with some genes from our parents. We cannot change that. Mm-hmm. But we can change how these genes work. And we all have cancer promoting genes and we have cancer silencing genes. If you live a healthy life, then you will stop those cancer promoting genes from being active, mm-hmm. and you will activate your cancer stopping genes. Mm-hmm. And we know that this works in prostate cancer very well. So they should believe me that health style is a major factor for the development of prostate cancer. And even if they have developed prostate cancer and receiving prostate cancer treatment, we know that if you move to a healthy lifestyle, your response to treatment will be much better. You will live a longer life. You will live a more healthy life.
Please tell me if a person has in his family a man who had this disease or maybe died, he should do this kind of analysis that you said earlier from a more early age, or if he knows that maybe his grandfather or father had this, so what this person should do.
Yeah, I'm that person. So my grandfather died of prostate mm-hmm. cancer. Mm-hmm. My father developed prostate cancer, but he was very, very old. Thank mm-hmm. you. And my uncle had prostate cancer treatment. So, and we know that 15% of prostate cancer is hereditary. So I definitely mm-hmm. have those genes waiting there. Mm-hmm. Well, if you have a family history like me, you should start having your PSAs at the age of 40. Today, our suggestion is to start doing PSAs at the age of 40 mm-hmm. if you have a prostate cancer in your family. And you should get some rectal examination from time to time also along with it, because sometimes the PSA will not be elevated in some prostate cancers, and it will only be detected by physical examination. So they should go both hand in hand. And the other thing is, as I explained before, try to live a healthy lifestyle. Mm-hmm. I go to the gym 4 times a week. I run like 2 times a week. I sometimes do cycling. I try to eat healthy. I try to avoid getting fat. So these are the things that need to be done. Mm-hmm. So far, my PSA is perfect.
It's very good that also as a doctor you have a healthy life, because there are sometimes cases when a doctor treats other people from a disease, but he doesn't do these things for his life. Yeah. It's very often. So it's really very good. I wanted to ask you if in your experience you had patients at a young age with prostate cancer.
Yes. The common opinion is usually that prostate cancer is a disease of the elderly. With the use of PSA, now we diagnose prostate cancer at much younger ages. We have a lot of patients in their 60s. We have many patients in their 50s. I have seen patients who died of prostate cancer before reaching the age of 40. Of course, these patients are a small number of patients, and they're very unlucky patients, because even before reaching the limit of suggested 40, they developed prostate cancer and passed away. But it's not a disease of the old, like the grandfathers. It affects a lot of men in their middle ages. And of course, it's an important factor impacting their life. Yeah.
Mm-hmm. I know that symptoms of cancer in general sometimes are not seen, but very often people know that they have cancer at an old stage when it's very hard. It's a hard case, but. What are the symptoms for prostate cancer? Maybe men can see something that should make them feel that they should go to the doctor and to make some analysis. Maybe they can feel something is not okay.
Well, prostate cancer doesn't have specific symptoms for that disease. Only later in the stages of the disease, it may cause some symptoms, which would be urinary problems like frequent urination, difficulty with urination, blood in the urine. But these are all late symptoms of prostate cancer. And these symptoms can be seen in benign enlargement of the prostate as well. So if a patient, I always say a patient, but if a man has urinary problems, he should always consult a urologist, and the urologist will do the PSA, will listen to him, will do the examination and decide. But the important thing is, unfortunately, there are no early symptoms of prostate cancer. And again, at the late stages, when they develop metastases, they may come with bone pain, they may come with loss of appetite, loss of weight, but these are all at the very late stages advanced stages of the disease. Yeah.
If you talk about another revolutionary method that is dealing with prostate cancer, is MRI biopsy. What you can say about this?
Well, MRI has been again one of the very important advancements in prostate cancer management. We talked a lot about PSA. So when someone has a PSA that's above normal, now the next step we want to do is an MRI. Because if the patient has a cancer within his prostate that needs treatment, we call it significant prostate cancer, a good quality MRI will see that in 85% of the patients. 85% is a very good percentage. And the MRI helps us in two ways. One, based on the MRI, we decide to do a biopsy or not to do a biopsy. And if we are going to do a biopsy, now MRI shows us where the target is, where the suspicious cancerous part of the prostate is. So we can put our needle into that target and know precisely if the patient has cancer or not, and also have important information from the biopsy details that's going to help us plan the management of that patient. To do this targeting, again, we need technology for our help. There's something called MR ultrasound fusion biopsy. You need a device which has a very good software, and you upload the patient's MRI, and the machine makes a 3D image of that. And then during the biopsy, you do your ultrasound, transrectal ultrasound. You take a 3D image of the patient's prostate during the biopsy, and you upload that to the machine. And the machine does a fusion. It's not a simple overlap of the images. It makes a very complicated fusion. So during the biopsy, by using the ultrasound, now on your screen, you can see where the suspicious area in the prostate is, and you can really 100% hit that target. Even if it's 3-4 millimeters, you can hit the target, and you can sample the most suspicious area within the prostate. Let me tell you the alternative, so maybe our listeners will have a better understanding of what I'm talking about. If you do not do an MR ultrasound fusion biopsy, the alternative is a standard prostate biopsy. What is a prostate biopsy that is standard? You do again an ultrasound biopsy. the ultrasound resolution is not good enough to show you where the cancer within the prostate is. The ultrasound only gives us the contours of the prostate, where the prostate is, and helps us guide our needles into the prostate, but not to the target. So you sample 10 to 12 pieces from the prostate, and that samples about 0.02% of the prostate. If the patient is lucky, the needle will hit the cancer. If the patient is unlucky, it will miss the cancer. So it's a very blind biopsy method. Mm-hmm. And MR ultrasound fusion biopsy is a huge advance because we know where to biopsy from, we can target that area, and we know for sure, almost for sure, if the patient has cancer or not.
Oh, yes, there are many cases detected at an advanced stages. We know that there are new treatments available even in very advanced stages of prostate cancer that gives hope to patients affected by it. As I know, you work with lutetium, and we want to know more about this because this kind of treatment is not available in Romania, and it's available, as I know, in Turkey. So we want to know about this, how it works and what is it.
Okay, let's start with treatment of advanced disease, new treatments, and then go to lutetium.
Of course, yes.
Okay, so I think the major advance in the treatment of prostate cancer within the last 10 to 15 years has been in the area of advanced and metastatic disease. There are a lot of new medications, new treatment modalities for advanced stage prostate cancer, and each of them increase survival. Survival means how long the patient lives. And when in general you speak about a cancer and a new medication causing a survival advantage, this is about 2 to 3 months in general. That's not the case in prostate cancer. Our new treatments increase survival like 17 months. 1.5 years, 2 years, each treatment increases survival that much. And that's a huge treatment advantage for the patients. There are a lot of new medications that we use in the earlier stages of advanced disease. The standard hormonal treatment that we have been using for many, many years is not good enough for our advanced patients anymore. We start with at least 2, and sometimes, based on the patient's metastatic volume, 3 different medications at the beginning. So we give a more effective treatment from the beginning. Genetic testing is becoming very important in prostate cancer. If you do blood analysis and tissue analysis, you see that in the advanced disease, 1 in 4, 25% of the patients have a genetic mutation. Mm-hmm. And now we have some specific drugs to treat the patients who have a specific genetic mutation. That's very important. That's called precision medicine. So we can choose the treatment on the patient's tumors, genetic mutations. And I think this will be the way to go in the next 5 to 10 years. This will be a huge issue. Everybody will be getting a different treatment based on their molecular type of prostate cancer. Well, what is lutetium? There's something called PSMA, prostate-specific membrane antigen. This is a molecule that is produced more by the prostate cancer cell compared to the normal prostate cell. We call it overexpression. So it's more abundant on the prostate cancer cell than the prostate. Now, we can use this PSMA as a biomarker. Suppose we can give the body a compound, let's call it a radiotraceable compound, and that has an affinity to go and attach to this PSMA. When this PSMA is expressed in each prostate cancer cell, it can be within the prostate, it can be in the lymph nodes, it can be in the bones, anywhere. The PSMA is overexpressed anywhere where the prostate cancer cell is. So if we give this radiotraceable compound, it will go and stick to the PSMA wherever it is in the body. And then if we have an imaging modality to look at this PSMA-bound compound, we can see where prostate cancer cells are inside the body. This imaging modality, which nuclear medicine does, is called a PSMA PET. And I think PSMA PET has definitely changed the landscape of prostate cancer. Now we see what we couldn't see. And when you see where the real disease is, you have a real better management plan, right? You know what kind of animal you're dealing with. Compared to the conventional imaging, which is a CT scan and a bone scan, PSMA PET gives us a much, much better, precise knowledge of the extent of the disease. Now, this is the use of PSMA for imaging. If the patient has a PSMA PET positive and has metastases, so we do the PSMA PET and we see that he has bone metastases. What if this time we inject a radioactive substance that will go and stick to the PSMAs, okay? Last time we did the radiotraceable one and we could image it. Now we will send something that is radioactive. It will go and stick to each PSMA producing prostate cancer cell within the body. And once it sticks there, it will send local little radiation to those cells and kill all those prostate cancer cells. Sounds magical, right?
Yes, of course.
Yeah,
it's like a war.
This is possible, and this is the basis for the lutetium treatment. Lutetium-177 is the magical compound that we send. It goes to the PSMA producing prostate cancer cells and kills each cancer cell within the body. Lutetium treatment has been a new door, a new opening, a new treatment option for our metastatic prostate cancer patients. It increases survival. It gives them a longer and healthier life. Today, we use it when they fail the new hormonal agents and chemotherapy, but with new studies coming up, we may be using it in early stages as well. But today we use it after the conventional, let's say, treatments have failed. Lutetium is a new treatment modality.
Also, as I know, you use robotical surgery for treatment. Can you say us more about this, how it works, and how is this operation? How is this surgery?
Yeah, robotic surgery has been in use about 20 years now. I've met the robot in 2004 in Seattle when I was there. Robotic surgery makes the laparoscopic surgery easier. And what is laparoscopic surgery? Sometimes it's referred to as the keyhole surgery. You don't have an opening, you don't have an incision, but you go into the abdomen through small cuts. The robotic instruments, you can just make a cut that's 8 millimeters, and then there are instruments and camera going into the abdomen. And these arms of the robotic system will be used by the surgeon at a console. The surgeon is not there in the same room, the patient and the surgeon, but the surgeon is not at the bedside. He has a console a little bit away from the patient. There's an assistant by the bedside near the patient. And from his console, the surgeon with his fingertips can manipulate all these instruments. The major advantage is that you have a 3D camera inside the patient. You can bring the camera almost into the prostate. You have a very enhanced, perfect image. You see better, so you can do more precise work. There's absolutely less bleeding compared to open surgery. Patients recover more quickly after surgery because they don't have a big cut. And outcomes of functional outcomes after prostate cancer surgery, which is urinary continence and erectile function, are reported to be better in centers with robotic experience. And that's the case in our hands as well. We believe that our results regarding urinary continence and erectile function, preservation of erectile function, is better when we use the robot.
When you recommend this kind of surgery?
If the patient is eligible for prostate removal and has a prostate cancer, this can all be done with robotics.
But who is eligible for this?
Well, that's a tough question, but let's say if the patient has local or locally advanced disease, sometimes disease in the lymph nodes as well, based on PSMA PET, all these patients, so local, that's disease within the prostate, or locally advanced or lymph node positive clinically patients can all be treated with surgery, and all of the surgery can be done with robotic surgery.
What is the success rate in that cases that were detected early?
Well, that success rate is given in the literature as 5-year cancer-specific survival rate. That means how many of these patients who were diagnosed at an early stage of prostate cancer will not die from prostate cancer in 5 years. And the numbers are very good. About, in general, 99% of them will be well and alive in 5 years. Sometimes 97 to 99%. So those are super numbers for prostate cancer survival if disease is detected early.
Okay, say us please how Romanian patients can contact you and can have a consultation with you. Because as I know, here, even in Iași, you have a representation.
Yes, we have an officially representative office here of Acibadem. Iana Aydemir runs the office. It's located in Kopo, Iași. And if the patients are interested in contacting us, they can contact our office here, and they will directly contact me for their evaluation.
What should know patients before coming to you? Or maybe there are some questions that bothered you, or you want them to know that all the cases are different?
I want to know, their symptoms. I want to know their PSA value. I want to know their general health, if they have cardiac problems, if they're diabetic, if they have neurological disease, if they have had surgery in the past, I want to know that. If they're using aspirin or any blood thinners, I want to know that. And if they have done tests like a CT scan or a bone scan or an ultrasound, I would like to know the results of all of those. I am happy to consult them online to have a better feeling, to talk to them, to understand them, to answer their questions. I'm always happy to do that because I think it's a much better way of communication rather than reading papers when you talk to the patient and he has his questions and you can answer them. All of this is very doable.
For example, here in Romania, because you work also with Romanian people, maybe in your experience you observed something that they don't know about prostate cancer, or maybe they don't know about this kind of advanced technology that you have in Turkey, in Istanbul. Maybe you can give them answer from this interview to know about this technology, or how it works, or what they can do in Acibadem in Turkey and they cannot do here in Romania, for example.
Well, I know that PSMA PET is not yet available, and lutetium treatment is not yet available in Romania. I'm sure it will be soon, but not today. I think they're both really very important. I mean, today I've been introduced to PSMA very early. Turkey was the second country after Germany to start PSMA testing, and it started at the University of Istanbul, where I was working at. So I've been using it for more than 10 years. And as I said previously, I think it has really changed the landscape of prostate cancer. Now we see what we could not see before. And when you see the real disease, the real animal, then you plan your management according to that. And anyone who has a risk of metastases, I think, should have a PSMA test done before starting treatment. The whole treatment may change. I mean, are they going to have surgery or not? Are they going to have radiation or not? Are they going to have hormonal treatment? For how long are they going to have hormonal treatment? All this scenario may change based on the PSMA PET. For example, from my last trip to Romania a couple of weeks ago, I saw a gentleman and I thought he had a risk of metastases, but the bone scan and CT scan said he had local disease only. And he came to Istanbul with the PSMA PET, and he learned that he has a bone metastases. And now the bone metastasis will be treated as well with radiation, and he will receive a long-time hormonal treatment. So his treatment plan changed, and I see this on a daily basis. And lutetium, we talked in detail, is a totally new window, an opportunity for the patients. When they have failed other treatment options, I think if they're eligible for lutetium, I think they should take that chance, come visit us and receive lutetium treatment, because it increases their survival. I've seen patients who have numerous metastases. You cannot count them. They receive one treatment of lutetium, PSA goes from 500 to 0, and in the new PSMA PET, there is 0 metastases. All of the metastases have gone on the PSMA PET. It's very dramatic, and I think it's a very important treatment option.
Yes, it's really very good results, because when you have
unbelievable.
Metastasis, it's a very hard
magical,
stage. Yes, it's really a very hard stage. How you are before? How you are accepting being a doctor? How you are as a person? What hobbies you have? How looks your life when you are not a professor, a science man, a urology specialist?
I have a simple life, not very complicated. As I said before, I like exercising. I go to the gym 3-4 times a day. I like running. I like spending time in the nature with my family. I have a daughter, and I have a wife, a daughter, and we have a German Shepherd dog who is more than 12 years old now. My daughter is studying in the United States. She's studying animation in New York. So she comes only in summers now. We see her rarely. We like to spend time in the nature. We like to travel nationally and internationally, explore the world. We live a little bit outside the city in Istanbul, in a suburban area where it's green, like Iași. There are a lot of forests and there's a lake, so we spend time outside in the nature. Istanbul is a very active in art. We are art lovers, so on Sundays we usually go to the city and see 1 or 2 art exhibitions. There's always something going on in Istanbul. It's very active, so that's something we like. And in the evenings after a long day, we like to watch a movie on Netflix, something like that.
Yes, a happy life of a person.
I think so, yeah.
How is Iași for you? Because as I know, you are here first time.
Yes, I liked it very much. I have seen little. I wish I could spend some more time, but tomorrow we have elections. We're going to elect the mayor of Istanbul, so I have to go and vote. But it's green, it's calm, nice, old buildings, very appealing to me. I like antiques. I like old, anything old. So I enjoyed it very much. Yeah, it's nice. I hope I will come back.
Of course, we are waiting for you, maybe for another interview, another kind of subjects that will appear after. I want to thank you that you come today and gave us very important information about prostate cancer, because really very many persons that have it. So we should talk more about this, and men should be more interested in their health, more interested in doing the analysis that are recommended. So I think it's very good we had you today.
It was my pleasure. Thank you very much for having me.
You're welcome. Aici se încheie podcastul nostru de astăzi, BZI. Alături de noi a fost profesorul și doctorul Can Öbek. Ne-a vorbit despre cele mai noi tehnologii din domeniul tratamentelor pentru cancerul la prostată. Nu este un subiect de ignorat, trebuie să discutăm mai mult despre asta și prin intermediul acestui interviu am vrut ca cei din România să aibă acces la această informație și la cele mai noi tehnologii pentru a înțelege cum se pot trata și cum pot poate chiar și preveni această cruntă boală, pentru că, așa cum spuneam, este destul de răspândită. Aici se încheie podcastul nostru. Noi ne vedem și la alte episoade de podcast BZI. Până atunci, faceți cumpărături pe site-ul Balkan.ro. Profitați de reducerea de 10% și folosiți codul BZI10 pentru a putea beneficia de ea. La revedere!
30 years ago, in 1991, a small hospital welcomed its first patient in a district of Istanbul, Turkey. Acibadem was the name of that district. Today, Acibadem Healthcare Group is a global brand providing superior medical services in Istanbul, Ankara, Bursa, Eskişehir, Muğla, Kayseri, Adana, and Izmir. Through acquisitions, our footprint expanded to Macedonia, Bulgaria, the Netherlands, and Serbia. In 2012, Acibadem signed a joint partnership with IHH Healthcare, becoming a part of the world's second largest healthcare group. Today, IHH Group is operating with more than 15,000 beds and 65,000 employees. More than 5 million patients yearly visit Acibadem facilities located in 5 countries. To meet all their needs, Acibadem has around 23,000 employees, over 3,000 hospital beds, and spacious service areas designed for optimum healing and comfort. All of the hospitals within the group meet and exceed global standards. Acibadem is well known for its world-class medical centers in oncology, organ transplantation, brain surgery, healthcare, spine surgery, robotic surgery, IVF, sports medicine, and aesthetic medicine. Here, top medical experts using the latest technology join their efforts in a multidisciplinary approach to push the boundaries of modern medicine. Since 1991, the key values of Acibadem Healthcare Group have been patient safety, patient satisfaction, and employee satisfaction. Following these values, we created an ecosystem providing patients with all necessary services at the hospitals. A+ deals with catering, cleaning, and laundry by international standards of service. Acibadem Mobile offers home care and emergency services. Acibadem LabMed renders laboratory services. Acibadem Project Management constructs turnkey healthcare facilities. Acibadem Technology develops and produces software as a hospital management tool. Acibadem University supports the education of healthcare professionals. Every year, more than 50,000 international patients from 96 countries choose to come to Acibadem hospitals in Turkey for their treatments. To provide comfort, trust, and stability to our patients, Acibadem designed Health Point Service. International patients can bring their medical reports to our contract offices and ask for a second medical opinion. Our physicians in Turkey check every report and provide a personalized treatment plan. When patients decide to come to Turkey for treatment, They are warmly welcomed at our Health Point lounge in airports and transferred to the hospital by Health Point vehicles. At Health Point desks located in our hospitals, our patients are welcomed by translators and supported throughout their treatment journey in 20 different languages. From the very beginning, Acibadem has been known for its medical expertise, advanced technology, and exceptional hospitality. 30 years later, we are here to keep on improving healthcare, touching lives, expanding the knowledge, and welcoming each patient as a dear guest. Excited about the next chapter of our future.